All right. I think we're ready to get started here. Okay. So welcome everyone to the oral health webinar. This is the third of the four-part series that we've been doing. And my name is Mihei Jung. I work as a Southern California Policy and Outreach Manager at California Pan-Ethnic Health Network, CPEN. And I'm going to be your facilitator today. And like I said before, this is the very first webinar, or this is the third webinar of a four-part series. And together we're exploring the topic of oral health in California. And the goal of this webinar series is to build a foundational knowledge on what oral health is and how it's delivered so that we can best serve our communities. Okay, so next slide. Okay, so the reason why we decided to do this webinar at CPEN is that we have partners all over California, and some of them are new to the field of oral health, and some of our experts, and there's a lot to learn for all of us. And they told us that navigating oral health landscape is a huge priority in their communities, and so that's why we started to do this webinar. And already, it's been very successful. We've had, many folks that have told us that this is helpful to them. So we're really happy to provide this resource for you. And there's been 4 webinars that we've done in this series. And so the first one, we talked about navigating Denti-Cal and understanding oral health. And the second webinar was all about understanding oral health coverage and, talking about specific oral health procedures. And third topic, which has, been gathering a lot of interest, is understanding who else can provide oral health services aside from dentists. So these folks are called, different terminologies, but I think popularly they're called dental teams. And so that's what we're going to talk about today. And so please also note that the fourth and the last oral health webinar is going to be all about highlighting oral health work in our communities, and that's going to be on September 6th. So if you'd like to register for that, you can go to the cpen.org website and click oral health webinar link, and there's a register section on that page. So please feel free to register for our last webinar on September 6th. Okay, next slide. Okay, so a little housekeeping here. This is a learning environment for all of us, and our presenter is a resource to you and to me. Please put any questions you have in the question box, and it will be monitored. Don't be afraid to ask questions. Again, this is a learning environment, and our speaker and our presenter is here for us, and she's a resource. The bulk of the presentation will be about 40 minutes, and then we will have about 15 minutes to do Q&A. And you all have joined the webinar in listen-only mode, and you are muted. This is a very popular question we're receiving. Will the webinar be recorded? Yes, the webinar will be recorded, and all the other 2 webinars that we've done, they're also recorded and available on our YouTube. Slides, handouts, recording, everything will be sent out to you tomorrow and will be available for you. So we have Dr. Jean Moore with us today, and we're really, really grateful to have her. She's been doing the work in the field for a long time, and she is currently the director of the New York Center for Health Workforce Studies at the School of Public Health, State University of New York at Albany. Dr. Moore serves as a principal investigator for 2 cooperative agreements funded by the Health Resources and Services Administration, the Oral Health Workforce Research Center, and the Health Workforce Technical Assistance Center. She has extensive experience in health workforce research and planning. Dr. Moore received her doctorate in public health from the SUNY Albany School of Public Health. She also holds 2 master's degrees in nursing from Russell Sage College and a bachelor's degree in nursing from SUNY Plattsburgh. And she's joining us from the East Coast, so we're really, really happy to have her. I'm going to turn it over to you, Dr. Jean Moore.
Thank you. Next slide. Great. That you can go on to the next slide. Everybody knows who I am. So I just want to say a little bit about the New York Center. So the Center for Health Workforce Studies, as was mentioned, is based at the UAlbany School of Public Health. We've been around since 1996, and we do what our name implies. We study the health workforce, collecting, analyzing data to understand workforce dynamics and trends. And our real goal is to inform public policies, the health and education sectors, and the public. The resources we get to do our work comes from a variety of sources. Next slide, please. So one of the sources of funding is the federal government. And in 2014, we were awarded funding to establish a cooperative agreement focused on oral health workforce research. And when we developed this, we did it in collaboration with UCSF School of Dentistry, and specifically Beth Mertz, who's a very well-known and highly regarded oral health workforce researcher. So the focus of our work really is about trying to understand where the access problems are for vulnerable populations, and then looking at workforce strategies to improve the situation. Next slide, please. So I'm going to be talking with you today about research we've done at the Oral Health Workforce Research Center. And of course, first thing I want to do is acknowledge the researchers who contributed to the work. They're listed in the first bullet. And also acknowledge the American Dental Hygiene Association. They've been a collaborator of ours for many projects, and some of the things I'm going to be showing you today, honestly, I think we couldn't have done it without them. So the other thing I have to say that the HRSA wants us to make clear is that the information, conclusions, opinions expressed in this presentation are those of the authors and do not necessarily represent positions of HRSA. Next slide, please. So I want to start, and given who the audience is, I'm quite sure I'm stating the obvious, but poor oral health is a significant public health problem. And back in 2000, then Surgeon General David Satcher released a report that really shone a light on this. Identified dental caries as the most common chronic disease of childhood. Identified links between oral and physical health, things like diabetes, periodontal disease, preterm birth. And I think over time that list has grown, and I think the connections between oral and physical health are quite clear. And there are a lot of things that contribute to this problem. One is that delivery systems tend to be siloed, that you have dental services available in one place and, say, primary care, behavioral health services in other places. Separate payment mechanisms. There are many people who have health insurance but don't have dental insurance. Impacts of social determinants of health. I think that we're starting to pay a lot closer attention to that, and also recognizing that oral health literacy is an important concept and something we need to pay more attention to. Um, Uneven access to dental services. So, as some of you may know, many state Medicaid programs do not cover adult dental. I understand that California has recently reinstated adult dental benefits, and I think at times when budgets are tight and state lawmakers, policymakers think about what has to give, a lot of times dental tends to be very, very vulnerable. So again, Medicaid may or may not cover adult dental, but sometimes even if they do, a lot of dentists don't participate in Medicaid programs. They don't feel the funding is sufficient, variety of reasons. So again, there are a lot of things that contribute to the problem of poor oral health. Now, just last week, I read in the Federal Register that there are plans to update this report. And I think we're all very excited about it, but honestly, we're scratching our heads and saying, how much has really changed? Anyway, I think that the bottom line is there are things that are changing, particularly around workforce strategies, and that's what I want to talk with you about today. Next slide, please. So, what's changing in the oral health landscape? Well, for one, there's more attention being paid to prevention and early intervention, recognizing that if people get the care they need early on, they may not need the more costly restorative services. As I mentioned earlier, efforts to improve oral health literacy, helping people understand the value of seeing a dentist for getting oral health services for prevention to minimize the need for treatment. Growing importance of risk assessment, triaging patients to the most appropriate level of care. There's also increasing use of technology, and this has been pretty interesting. There's a lot more efforts in things such as teledentistry to find ways to create access, particularly in rural communities where it might be a lot harder to build much capacity for some of the services that are needed. And finally, one issue that I think is really quite exciting is that there's increasing efforts to integrate oral health services with primary care and behavioral health services. And I'm going to be saying more about that a little later in my talk. Next slide, please. I think that changes are happening in the oral health service delivery system. I think for a very long time that primarily if you wanted oral health services, that your principal option was private dental practices. But that's changing, and we're beginning to see the growth of dental service organizations. And sometimes dental service organizations limit themselves to providing administrative supports to existing practices. But sometimes they may buy up practices and consolidate them into group practices. They may actually provide services. I'm sure you're familiar with the Aspen Dental chain, others that go out and market services and actually have infrastructure to deliver care. We actually did a study. The Oral Health Workforce Research Center did a study on dental service organizations, and I will tell you our conclusion was that there's a tremendous amount of variability in what they look like, what they do, and also the extent to which they are helping address issues around better access to care. But again, they're around and appear to be growing in number. We're also seeing a lot more oral health programs in community-based settings, and a couple of really good examples are school-based clinics, oral health services being provided in nursing homes, and I have some examples I'll be sharing with you later. And for a number of them, dental hygienists are kind of the movers and shakers in some of these. Safety net providers that integrate oral health, primary care, and behavioral health. Now, I will tell you that FQHCs have really done a lot in that area. I think that FQHCs, just by virtue of who they are and what they're supposed to be doing, are providers of underserved populations, and finding ways to create access to services that is considered one-stop shopping is really important. And finally, all of these changes are contributing to workforce innovations, which I want to say a little bit about. Next slide, please. So workforce impacts, what are they? First of all, as mentioned in the opening, use of team-based models of care. You know, I think when we think about sort of the traditional dental office, the team was sort of a hierarchical model. You had the dentist in charge and others were kind of working under the dentist. That's changed now, and teams are much more collegial and work together as peers in service delivery. So I think that the sorts of team models we see are changing as part of what's happening. There's an expansion of roles for the existing workforce. EFTAs, or expanded function dental assistants, are available and in greater numbers. And I will say that there's a lot of perhaps inconsistencies in how one could become an EFTA. Some states require more training. Others allow it to happen as part of on-the-job training. Some are required to be certified. And as a result of those different pathways, EFTAs in different states are allowed to do different things. So it contributes to variation, but I think the bottom line is that it creates a pathway for dental assistants to be able to learn more, do more, and have a career path. Another important area, and this is really going to be a focus of my talk, is what's changing with dental hygienists. So there are any number of titles that you see, and again, it tends to be state specific. Public health dental hygienists, independent practice dental hygienists, collaborative practice dental hygienists, and in California, the RDHAP, which is the Registered Dental Hygienist in Alternative Practice. For a lot of the places that recognize expanded practice, many of them are tied to more autonomous practice in community-based settings, working with underserved populations. So in a lot of ways, it's geared to meet unmet need for oral health services. There are also new workforce models. So there's a category of worker called the Community Dental Health Coordinator. And this was actually a concept introduced by the American Dental Association. There are a small number of programs around the country that offer it. And I think if I had to succinctly describe what it is, it's about a community health worker with an oral health focus. So doing the sorts of things that finding people who have unmet need for service and helping connect them to service. And there's also dental therapists and dental hygiene therapists. And this is probably one of the newer and up-and-coming strategies for creating better access to basic restorative services. So essentially, dental therapists, dental hygiene therapists, with training are able to drill and fill to provide basic restorative services, usually under the supervision of a dentist. And they're becoming increasingly important as a strategy to care for underserved populations. Right now, there are dental therapists in Alaska, and it was something that was developed by the Alaska Tribal Council that felt very strongly that their members had very limited access to needed services and often wound up going into oral health crises that required them to go to emergency departments. So this was an attempt to change that. They encountered a lot of resistance from organized dentistry, but nonetheless persisted and were able to establish dental therapists in Alaska. And there have been many evaluations of dental therapists, and so far everything points to the fact that dental therapists perform as well as dentists, that there really isn't much difference in quality. Minnesota was the next to adopt dental therapists, and they actually created two levels. There was the dental therapist and there was the dental hygiene therapist. And the dental therapist obviously wouldn't come out with hygiene skills, but dental hygiene therapists could provide both preventive and restorative services. And they've been very successful and actually written into the statute, I believe. They're required to have half their patients, half their panel be underserved. So it's proved to be very, very fruitful. Again, they haven't been around long, but the evaluations seem very promising. They've been able to reduce emergency department visits. Again, they've been able to provide high quality care. And Minnesota is actually migrating toward training the dental hygiene therapists and exclusively. And I think the premise is that the employers of the dental therapists really like the versatility of a dental therapist who can also provide preventive services. And then finally, the engagement of medical professionals. So as efforts go forward where primary care and oral health services are integrated, an increasing number of primary care physicians are being trained to screen the oral cavity and make referrals for oral health services as needed. There's an online curriculum called Smiles for Life, which you may be familiar with, and that's being used by many professions to help people understand how to conduct a basic oral health assessment. Next slide, please. So back to the issue of federally qualified health centers, and I mentioned the fact that they tend to be innovators. We've visited a number of FQHCs that integrated oral health with primary care, and I think what happens is that it just makes too much sense not to do it. I think that federally qualified health centers a lot of times have to really struggle to make ends meet, and creating an efficient system where the different parts of the system interact with each other, plan collaboratively, recognize problems. It's a two-way street. I mean, one center we went to, the primary care well child visit always included a dental hygienist who would come in and screen the child and talk to the parents again in efforts to improve oral health literacy. That same center had in their oral health clinic, they would check blood pressures before administering any anesthesia. One patient came in looking jaundiced, and they immediately brought him to the primary care clinic. So, the integration really creates some synergies that improve the quality of care and improve responsiveness to patient need. Next slide, please. So I also think that, as many of you may know, the federal government made a sizable investment in oral health expansions for FQHCs. And in talking to some of them about how they go about planning services, I think that there are certain themes that rise to the top. I think the first question you have to ask is, who are the patients and what do they need? What do we know about the services that are available? What do we know about sustainability of programs? How do services get reimbursed? And is there a way to make sure that the funding is sufficient for us to continue? And then another really important area is, what are the state scope of practice laws and regulations related to the oral health workforce, especially for dental hygienists? Next slide, please. So now I want to say a little bit more about scope of practice. So just when we say scope of practice, what do we mean? I think it's important to differentiate between professional scope of practice and legal scope of practice. So professional scope of practice is also known as professional competence. It describes the services that a health professional is trained and competent to provide. Legal scope of practice is based on state-specific practice acts, and it defines what services a health professional is allowed to provide under what conditions in a given state. Now, it sounds pretty straightforward, and you think, man, they're the same, right? Actually, they're not. Legal scope of practice and professional competence overlap, but the amount of overlap varies by state and by profession. I will tell you that dental hygiene is one of those professions that is characterized by wide variation in what they're allowed to do from state to state. Next slide, please. So my center back in 2001 decided that we wanted to try to take a closer look at dental hygiene scope of practice. So we built something called a Dental Hygiene Professional Practice Index that we call DHPPI, and it allowed us to look across states at various scope of practice issues and understand or measure the variation. So the way the index worked is that there were variables that were grouped into 4 categories: regulation, supervision, tasks, reimbursement. And on this index, a state could score anywhere from 0 to 100, depending on what the state did or didn't allow. So we used this 2001 DHPPI and reviewed state scope of practice laws in 2001 and again in 2014, so we could actually compare states to each other around dental hygiene scope of practice. And then we actually updated the index in 2016 and scored state dental hygiene scope of practice in 2016 as well. Next slide, please. So this is the map of the dental hygiene scope of practice scores in 2014. Again, based on a review of laws and regulations. Now, if you'll notice on the map, blue are higher scoring states, which have an excellent practice environment for dental hygienists, of which California is part of. Now, if you look at low scoring states, Southeast U.S. Really offers a very restrictive practice environment for dental hygienists. Next slide, please. So then we started thinking, A dental hygiene professional practice index developed in 2001 might not really reflect today's ideal practice for dental hygienists. So we decided we wanted to update the index and try to get it closer to today's reality for dental hygienists. And the things we thought about were things like a hygienist's ability to supervise dental assistants, which wasn't in the original, the provision of restorative services, like I told you, the advanced practice or the dental hygiene therapist, the ability to provide local anesthesia without direct supervision. Next slide, please. So here's our updated index, and again, the excellent ones are still, on the West Coast. The restrictive ones are still in southeastern U.S. But again, we felt that it did a much better job of representing dental hygiene practice today, and we felt much more comfortable with it. Next slide, please. So then we asked ourselves, well, so what? Does this variation in dental hygiene scope of practice really matter? So we set out to answer that question. Essentially, do more expansive scopes of practice impact oral health outcomes? And so for each of the years that we scored dental hygiene practice in states, we used something called multi-level logistic modeling, where we controlled for a lot of the usual sources of variation in oral health outcomes, and we included the Dental Hygiene Professional Practice Index as one of the things we looked at. Next slide, please. And the results were pretty astounding. We found that the scope of practice score exerted a positive and significant impact on adult oral health. More expansive scopes of practice for dental hygienists in states was positively and significantly associated with having no teeth removed due to decay or disease among individuals in those states. And the footnote below is actually a reference to an article we published in Health Affairs that described the study and its results. Next slide, please. Now I want to give you just a few examples of how dental hygienists with more autonomous scopes of practice are expanding access to oral health services, particularly in community-based settings. And I think it's important to recognize that a lot of times these things are developed kind of based on local circumstances, so you see some variability. Next slide. So one program that we looked at was a virtual dental home, and this is actually built on the model developed by Paul Glassman, who developed the model in California. And it uses expanded practice dental hygienists to provide children in schools with preventive oral health services. And the children, this was a small rural community. Many of their parents worked in agriculture. And the dental hygienist provides services in schools during the academic year. And when school's out, she works in the office of the local pediatrician so that she's able to maintain consistent contact with children. And interestingly, the initiative is sponsored by a dental health maintenance organization that is a dental insurer. And we actually met with administration there who said, this makes an awful lot of sense to us. If we can provide needed preventive services, we can avoid the need for the more costly restorative services. Next slide, please. There was also a Colorado dental hygienist in independent practice who developed something she called Senior Mobile Dental, that over time included a fixed clinic, a mobile program, and used teledentistry. And her main focus was skilled nursing facilities. And eventually she added a dentist and was able to provide restorative services as part of this. Now, in her case, I think she used a combination of Medicaid reimbursement, if it were available, to pay for this, but she also used grants. When I say one size fits all, it's really important to think about how does one fund such efforts. And again, different programs used a lot of different, and in some instances, pretty creative strategies to do that. Next slide, please. Now, this is a really interesting one. Next slide. There we go. So we went to a federally qualified health center, the only Medicaid dental provider in that county. And there was a dental hygienist, a public health dental hygienist employed there, who also worked as a community dental health coordinator. So she spent part of her time in the community case finding, outreach, connecting, providing community education, connecting people to services. But the other part of the time, she provides preventive oral health services in the clinic, in schools, in Head Start programs, and primary medical practices. So ultimately, the community dental health coordinator role that she filled was in part paid for by the dental hygiene services she was providing. Next slide, please. So then we said to ourselves, my God, this is such important work. And, we have reports, 150, 200 page reports. We have a very, very scholarly article in Health Affairs about the work we did to show that scope of practice matters. But we said, how do we get the attention of policymakers? They're not going to read these things. So that's when we decided we wanted to build an infographic. And we wanted an infographic that, in shorthand, could help people understand the variation across states in dental hygiene scope of practice. So we collaborated, once again, with the ADHA, and as luck would have it, they were convening a meeting of dental hygiene leaders from across the country, and they allowed us to hold a series of focus groups with them. And we just said to them, here's a list of things that dental hygienists do. What do you think are the most important functions that can help expand access to preventive oral health services for underserved populations? Next slide. So lo and behold, this is the infographic we developed. And if you look at it, the wheel, as we affectionately call it, has a number of different regions, and within those regions, states. And we identified those tasks that dental hygienists, again, should be allowed to do given professional competence, and actually identified whether they would or wouldn't be able to do it in a given state. And so, as you can see, the variation is pretty dramatic. One of the things we try to do is get this into the hands of oral health stakeholders, coalitions who are looking to expand access to oral health services in their states, because we think this is a great way to help policymakers understand what is or isn't allowed. And it also points to the study that we did that said, and this really matters, this makes a difference. Next slide, please. So in closing, I think that it's important to recognize scope of practice when proposing or designing workforce strategies to increase access to and use of oral health, preventive oral health services. Dental hygienists with broader scopes of practice clearly can have impacts on high need populations in community-based settings and improve outcomes. I will also tell you that the infographic is a work in progress. I think about 2 hours after we posted it, we got a call from someone in a state who said, "Hey, wait, a law just passed here, and now we can do this." So we've decided that on an annual basis, we're going to collect information about changes to scope of practice law that we hear about, and again, we work closely with ADHA, who keeps us apprised of things they know about. And on an annual basis, we'll provide the most up-to-date information we have about dental hygiene scope of practice. I mean, it's exciting for me to think about how we might be able to sort of fill in the blanks and get more states to let dental hygienists do more of what they know how to do. So that's the end of my presentation. You can go to the last slide with contact information, but thank you very much. I guess we'll open it for questions now.
Thank you so much, Dr. Moore. Your research is really interesting. Can we actually go back to that scope of practice slide?
Sure.
I think that visual is actually the circle. Yeah, and I just wanted to kind of point to, because all of us are doing work in California, and folks that have been following this journey of oral health webinar, they're doing a lot of deep work in communities and communities color, and so what can you just describe to us the scope of practice in California? And I see that we have the different things that we can do, the dental hygienists in California that they can do. Can you just go into that and describe more of the California scope of practice?
Actually, what I want to do is point out that just because a state allows dental hygienists to do certain things, it doesn't mean everyone does it. So my suspicion is that as we look at dental hygiene scope of practice, we're looking at, what will a state allow? Now, you've got the RDHAP, and so what I suspect is that the dental hygiene scope of practice in California, because it recognizes and allows RDHAPs, that that's very progressive. They, again, if you look at what they can and can't do, it's pretty extensive in terms of what they can do. But let me ask you a question: is every dental hygienist an RDHAP? No. And so a lot of times what you're describing is some of the more higher level opportunities for practice, but that not every dental hygienist in a state actually takes advantage of it. So I think it's important to recognize that in some ways it represents, possible practice in a state, but not every dental hygienist in that state is going to do it. So, again, we've only touched on what's possible, but we don't, again, it doesn't take you to the point of what are people actually doing and how close does it resemble what they could do ideally. You see what I mean?
Yes, definitely. So you're mentioning that as you mentioned, scope of practice in California is fairly generous, but that there are barriers. What do you think? Let
me tell you. So we actually did a presentation on this to the State Dental Hygiene Association in New York, and there had been a change in the law that recognized oh, I think it was collaborative practice or something along those lines. But it became clear the more we talked that most of the dental hygienists in the room were in private dental practices. And while they found it interesting and thought it was really neat, I'm not sure they saw that it applied to them. And, at some level, I guess it probably didn't. So my question is, are we doing enough to get dental hygienists who are in training to think out of the box about what's possible and what they could be doing and why access to care matters and that they hold the key? So again, I feel like there's a lot going on. I think dental hygiene is really well poised to become, and they already are really important members of the oral health team. But what do we need to do to go further? What do we need to do to increase the number of, RDHAPs, the number of New York dental hygienists in collaborative practice? I mean, how do we spread this?
Mm-hmm. Yeah, thank you for that. And we have questions that are coming in through our panel here. And one of the questions is, we work with many communities whose primary language is not English or who have low trust of healthcare institutions. Can you share some examples of how dental hygienists or other types of providers that you mentioned can provide more culturally and linguistically competent care?
So one area of research for us has been looking at diversity. And actually, Beth Mertz, who I would strongly urge, if you do more oral health webinars, to encourage her to participate, did a study of Hispanic dentists. And it was very telling. It really helped understand why diversity in a profession really matters and truly promotes cultural competence across the team. So I think diversity is a key issue. I also think that we don't do a particularly good job of recruiting people from underserved communities. And I don't think we have career ladders that support the kind of mobility we need to advance people through a pipeline in education. So, number one, I think diversity in dental hygiene, diversity in dentistry is extremely important. But I also think that recruiting people from underserved communities, again, for some of those communities, the lack of trust, I think there's a basis for it. I think things have been done in the past that are pretty awful, and that we need to find ways to change that. And the way to do that is to build linkages with the communities, and again, make sure that any program we start, we ask the question, who are the people in need? What are their issues? How do we build something that's going to work for them? So again, I think some of it is about being more aware of the communities we're trying to serve and designing systems that they're engaged in and they can help with.
Yeah, I think that's really helpful, and I think that's especially pertinent in areas where folks don't have access to dentists, also in rural areas, and how to develop that workforce and creating pipelines so that people that know the culture, can get fed directly into being healthcare professionals. So that's very helpful.
Right. By the way, another strategy in rural is teledentistry. We visited a federally qualified health center in upstate New York that works with migrants and has a number of different telehealth programs, but one of them is dentistry, where they focus on children. And they use the teledentistry program to kind of prepare for the visit to the dentist or the dental surgery suite, so that whatever happens in a much more methodical and perhaps less stressful way, both for the child and the parents.
Mm-hmm. That's really helpful. Thank you. And another question we have here is, you talked about dental hygienists as being part of a team-based care model. Can you speak more about who's part of this team?
So, again, I will tell you that we've done a number of site visits as part of the Oral Health Workforce Research Center. So when we've met dental hygienist entrepreneurs who've literally started programs and then built the program around a special need population and built the team from there. A school-based program that deploys a lot of dental hygienists in different schools. Again, at an FQHC, the dental hygienist is part of the primary care team and is involved in helping with well child visits and making sure that oral health literacy improves in interactions with parents. Let me think, what other places? The virtual dental home in Oregon, the hygienist is is filming an exam, and she looks at what it's showing, and she says, that looks like an abscess. I better get that to the dentist right away. So I guess it's the point of, it's no longer I work for the dentist and I do what the dentist says, but I'm part of a team. And if something comes up where I need a dentist or I need a dental assistant or I need, that I've got people I can call on. So roles are changing and it's much less hierarchical. And I think hygienists are being recognized as prevention specialists. And I think increasingly there are opportunities for them to serve in very important roles related to prevention.
That's great. I think the lessons learned is that, when working in communities of color and just myself too, when I have oral health issues, the first thing I'm thinking about is, how do I access a dentist? Where do I find a dentist? But as you're explaining that now there is a team and there are, folks that can provide different scope of services. And if, the basic preventative services and restorative, there are folks that can provide that. And I think that those are some key lessons learned for me. And also your research is really interesting. And thank you so much for sharing. And I think, one of the last questions we have for you is, what were some key stories you heard from dental hygienists through the focus groups that you conducted?
Well, let me just say that these dental hygienists came from around the country. So if you look at the infographic, the dental hygienist who joined our focus group from Texas bemoaned the very, very restrictive practice in Texas. I mean, it didn't stop her from helping us identify the things that could be very valuable if dental hygienists could work autonomously in community-based settings. But I mean, I think it gives you pause that there are dental hygienists even in those states with all those restrictions who really do have a commitment to caring for underserved populations, but recognize the constraints within their system. We visited a program. Oh gosh, it was one of the southern states that used telehealth for the delivery of preventive services in schools. And crazy, the telehealth application was designed so that a dentist sitting in an office 300 miles away was available should she need him, because that was the law. When in fact, you could have done so much more with that equipment to facilitate better care for the kids she was serving. But that was the law, and that was the restriction. So, sometimes I think you got to shine a light on, what are some of the things that we ought to be able to do to help facilitate that. By the way, the other thing I'm trying to do is get this infographic into the hands of oral health stakeholders in states, because I think that it's a great starting point for talking about what needs to change.
Mm-hmm. Mm-hmm. That's great. And I think our last question that we have for you is, a lot of folks that are attending the webinar today, they're community advocates. What messaging do you think would resonate with policymakers in making the case for expanding scope of practice to, allow dental hygienists or other dental team both to do more and to commit to better practice?
So I will tell you from past work that we've done, first you have to build a case about what the problem is. And, so some of it is about who are the populations that can't get care. And then the next step is to point to strategies that have worked elsewhere that could actually improve access to care. And I think one of the caveats, and I probably didn't emphasize this enough, but the changes that happen, dental therapists, advanced practice dental hygienists, the changes to laws, these usually are accompanied by tremendous struggles. Organized dentistry tends to feel very threatened by what they view as a ceding of their territory, losing ground. Somebody else can do things that were exclusively reserved for dentists. And, I guess the problem is helping people understand that, there are populations who just can't get the services they need from the dentists that are available, and that we do need to think about new ways and different strategies for creating access to care. But again, I think that efforts to try to change laws, even if it's to allow dental hygienists to have more of an opportunity to practice in community-based settings, it still comes with tremendous struggles from groups who are threatened by that. So I think it's important to recognize that a lot of the changes that happen with regard to scope of practice tend to be incremental. So, first, who's the population? What do they need? The other thing to do is identify, what price do we pay for not doing anything? What happens when somebody winds up feet first in the emergency room in a dental crisis that could have been averted by preventive care? So again, I think it's important to recognize the different aspects of the issues to lay out for people to understand why it makes a difference, why this ought to happen.
Yeah, well, that was really powerful. And thank you, Dr. Jean Moore, for your research and all your studies and sharing with us the scope of practice. And I think what you're saying is, it's all of our responsibilities, and that really builds a case for this new terminology, dental teams. How do we all, elevate ourselves to meet the needs of our communities? And there are constant challenges and threats to our communities every day. So really, really thankful that you are able to join us. And for participants and folks that are here with us, thank you so much for joining us. All the materials, as usual, and recording of this webinar will be available to you tomorrow. And if you have any questions or feedback or requests for further topics or speakers or presenters or things that you're curious about, just feel free to email me and contact me. I'm here to figure out what it is that folks need and be able to provide that resource for you. So thank you so much, Dr. Jean Moore, for joining us, and thank you to you participants. We're going to close the webinar now.